Hello, welcome to HSG's virtual presentation at the OHA annual conference. Today we're going to present on building a sustainable compensation strategy and talk about the best practices for employed provider compensation. First, I'll talk just a second about who we are at HSG. We are physically located in Louisville, Kentucky, the heart of bourbon country, but today we're excited to be with you in cyberspace. At HSG, we focus on employed physician networks and really help clients around 5 key needs. The first is physician strategy, which generally involves growth and manpower planning. The second is physician leadership, where we often help clients build and maintain provider leadership structures. The third is practice assessment and improvement implementation, where we often generate significant financial return for our clients within the realm of their employed medical groups. The next is physician network integrity analytics, where we help clients develop strategies for attracting and retaining patients. And lastly, physician compensation, which of course is what we're talking about today, but that for us also includes fair market value analysis, hospital-based subsidy assessments, and compensation plan design for both physicians and advanced practice providers. So today's presentation, as I said, is entitled Building a Sustainable Compensation Strategy. One of the things, like I said, we'll focus on is best practices for employed provider compensation. But we will also talk about the importance of having a compensation strategy that evolves with and supports your organization's progress towards value and high performance. And we'll talk about kind of some of the forces that are causing compensation structures to change within that. And then, as I said, we'll talk about best practices. A quick summary here of the description, which I've already gone over, some of the outcomes and supporting points per the description of the presentation, which I won't belabor. So we will go ahead and introduce ourselves. As I might have said, my name is Eric Andrioli. I'm a director here at HSG. Co-presenting with me today is Neil Barker and Terry McWilliams. And we will dive into it, unless Neil or Terry, any opening words of welcome to the group?
Happy to be here today and presenting this important topic.
I'm virtually amazed that we can be together like this.
Great, love that. All right, well, we'll dive in then. So one of the things I said we want to tackle first is really understanding what factors are pushing organizations to reevaluate their provider compensation plans. And there's a lot going on and a lot of factors, but we're going to boil it down to 3 major trends. 1, payer factors, 2, market and competitive factors, and then the third is internal factors in response to those prior 2. And we'll talk about kind of what we mean by each one of those as we go on. But the first is payer factors, as I said, and probably the biggest thing going on in the payer space this year and is causing a lot of organizations to look at 2021 as a great year to reevaluate their provider compensation strategy, is what CMS has done in terms of the Medicare physician fee schedule. So at the end of last year, Medicare finalized the rule for the 2021 Medicare physician fee schedule. And it did a lot of things. There were a lot of changes, but there's 3 that we consider kind of the big 3. The conversion factor was decreased. So that means for every unit, for every service, for every professional service billed to Medicare, the dollar unit going to organizations per relative value unit goes down. At the same time, they increased the work RVU credit for many E&M codes. And some of those were substantial increases. As we look at the table down here in the bottom corner of the slide, we can see 99213, probably the most popular E&M code, increased in terms of its work relative value unit from 0.97 to 1.3, a 34% increase. So huge increase for these particular codes. Given the fact that these are very common codes for many specialties, you can think about the resulting RVU increase for the same volume of work. So the other thing that the third component of what we consider the big three is the Office E&M coding changes. So the criteria and definitions around what constitutes a 99213 versus a 99214 versus a 99215 have changed. So those three things all work together to cause changes that are kind of going to be a little hard to predict. Because if we think about the coding changes, the curves in terms of the distribution of codes is going to shift. The RVUs associated with those are also shifting, and then the dollars coming into the organization are also shifting as well. And so all those things together cause significant impact and changes to the organization's revenue. And given the fact that most compensation plans, if they have a productivity component, that productivity component is work RVU, these changes also cause issues for provider compensation as well.
Eric, if I could just add into that, those E&M RVU value changes were specifically just for those office encounter codes, but the trickle-down effect was huge. So it's not just these codes that were affected, but many codes that are built upon the foundation of those as a baseline or their base foundation. So huge impact across almost all specialties, but a very highly variable impact across specialties as well.
Great point, Terry, which definitely leads into kind of the where we were going on the next slide, which there's a lot going on here. There's a lot of numbers, but essentially what we've done is we've looked at information provided by Medicare and also created some additional analysis to really answer a few questions and to say, okay, given the amount of dollars that Medicare spends within a specialty or on a specialty for professional services, given the projected increase of the work RVU values, and given the projected either increase or decrease of the revenue to the organization, what might we think about how these specialties are, faring in terms of this change to the fee schedule? And so there's a lot of columns here, and so I won't belabor this table, but essentially what we're looking at is how much Medicare is spending, the impact on the projected impact on dollars for the specialty, assuming the same volume, and what the impact on dollars is based on the Medicare fee schedule final rule that was finalized in December. But then after that, there was legislation that came in and made some changes, which actually increased the conversion factor after it was decreased, but it did not increase it all the way up to where it was. And so this column shows, the final result of the revenue projections based on the change that happened at the very beginning of 2021. And then this column shows the changes in work RVU credit that are projected for a specialty. So when we think about the specialty and how many work RVUs the specialty, or how many E&M codes the specialty is likely to use in proportion to other codes, if we think about all those other changes that Terry talked about to other work RVU values and say, for on average, the way to interpret this is for cardiology, the professional dollars coming into the organization for cardiology are likely to increase by 3%. However, the work RVU component is likely to increase by 9%. So the differences in RVU values are outpacing the increase in reimbursement by 6%. So you can see that unless an organization makes some changes to the rates or to their compensation plan, they might be upside down and they might be spending more on the provider compensation than the incremental dollars they're getting because of all this in terms of the revenue from Medicare. If we then compare to something like family medicine here, family medicine, the dollars coming into the organization increase by 11%. The RVU increases go up by 19%. So in other words, in that specialty, the differences in RVU outpace the reimbursement by about 8%.
And so, Eric, I mean, you talked on the previous slide about the moving parts with the changes in RVU values and conversion factor. And then you look at this and you can see why organizations are struggling, with a varied mix of specialties and different numbers of providers in each specialty and the varied impact, just a lot of moving parts right now.
Yep, absolutely. And so probably that is probably the main reason that a lot of organizations are looking at 2021 as a transition year. Most organizations that we've talked to or work with have decided to, when it comes to provider compensation, utilize the 2020 fee schedule as a basis for determining work RVU values, utilizing the same values per work RVU that they had in their 2020 provider compensation plans, and continuing to pay the providers along those parameters. So essentially that maximizes the chance that during 2021, if they utilize the 2020 parameters, maximizes the chance that providers will get paid approximately the same compensation for the same volume. A lot of organizations are doing that for 2021, then using data that understanding how the coding patterns are changing during 2021, and then also taking a step back and say, based on all the changes and all the data coming in about these fee schedule changes, how do we need to change our structure going forward to ensure that any dollars coming into the organization are being appropriately shared with the providers, but we're not upside down, and we don't become unsustainable because all of a sudden we've increased our compensation by more than we've increased our revenue. And so for that, 2021 is a transition year. It also allows a lot of organizations to step back and think about broader incentives and to say, okay, for a productivity model, are we really maximizing the behaviors we want? And maybe productivity needs to be a part going forward, but maybe we also need to either introduce or increase the amount of non-productivity incentives into our compensation plans. So for all those reasons together, a lot of organizations are taking 2021 as a year to really step back and just holistically evaluate their provider compensation models. And that coincides with a lot of other trends that we've been seeing over years, because this change to the Medicare physician fee schedule isn't the only thing that is kind of tinkering with the revenue coming into these organizations. CMS for years has been increasing the proportion of dollars that are tied to some sort of value component, and commercial payers are mimicking as well. And I won't go into a lot of details about these particular programs, because I'm sure a lot of this audience is very familiar with, in 2017, when CMS introduced the quality payment program, which kind of collapsed a few different models and created different tracks. And organizations either go down the merit-based incentive payments program, or they go down the alternative payment model system, where either way, there's dollars at risk for quality and outcomes tied to the organization. And that's on the professional side. On the hospital revenue side, Medicare even further ago, in 2013, introduced the hospital value-based purchasing program, which ties significant dollars to measure categories like mortality and complications, healthcare-associated infections, patient safety, patient experience, and even things like efficiency and cost. So the 2021 fee schedule, huge step forward, but definitely not the only thing Medicare's been doing to kind of tinker with the dollars coming to organizations, and certainly been shifting towards value. And we've seen that in all sorts of studies and in all sorts of numbers. If we look at this particular source, which comes from the Catalyst for Payment Reform, which is a kind of a joint effort from the Robert Wood Johnson Foundation and the National Alliance of Healthcare Purchasers. Even if we take just a 5-year period and we go all the way back to 2012, the amount of value-oriented payments was very low. 89% of all payments were pure fee-for-service, had no value component to them at all. By the time we get to 2017, that number goes down to 47%. and an equal amount of what is spent on healthcare in this country is tied to value. So 47% of the payments have some sort of value component. Now, those might be fee-for-service payments that have, some modulation based on value, but nevertheless, it's dollars that are tied to value. And so, it's not just something that folks like us are talking about. We're seeing it in the dollars as well. Terry or Neil, anything to add on kind of those two quick slides? All right.
No.
So then, interestingly enough, it's not just payers that are kind of creating this impetus for organizations to think more about value. Obviously, tying the dollars and the revenue streams to value is going to get most organizations' attention, but we've seen a huge increase in quality type messaging used in direct materials when being marketed to patients. There's also an increased public access to quality data and things like rankings. And so if we think about all these organizations out there that are trying to, get this information to the public, and if we think about all these organizations, healthcare and hospital systems that are using that information for marketing purposes, you can see too that even if we don't necessarily think about the revenue stream and the revenue stream being tied directly to quality, you can understand that things like market share, things like patient loyalty, things like brand positioning are increasingly being tied to these sort of quality things as well. And if we look at any of the programs on here, like if U.S. News Best Hospitals, more and more you drive down and you see billboards where a hospital or healthcare system, advertises or touts the fact that they're doing very well in that U.S. News Best Hospital ranking program, and that has things like patient outcomes, process measures, patient experience, all those tied into how those organizations rank these hospitals, which in turn directly ties into the brand awareness, market positioning, and market share for these hospitals. So that's another thing that's just increasing the focus on these measures.
And the public availability is out there, right? In increasing numbers. You can find this. And, even 5 years ago, back to that, 2012 to 2017 slide, those increases, many people said, well, we hear about consumerism in healthcare, but we don't really see it. Yeah. But now what we're seeing those numbers go, exponentially up with I think upwards of 80% of individuals indicating they look for public sources of data when making healthcare decisions now. So this really is impacting on reputation. It's impacting on patient attraction and patient retention. And people, even very well-known institutions, are trying to defend or refute the scoring they're getting on these publicly available sites.
Yep, great input, Terry. And so you can think about, with all that teed up, with dollars being tied to value, with how patients perceive us being tied to quality and value, you can think about how organizations need to evolve. And at HSG, we've kind of been observing this evolution for a while now. And Dr. McWilliams actually co-wrote a book on this evolution. And our framework is kind of teed up by what we call the network growth phases. And it really comes down to our observations that most networks, most employed provider organizations, they start out as a pretty fledgling physician group, not a lot of infrastructure, and really, if we think about health systems making acquisitions and just kind of starting in response to what's happening in the market, then they go through a phase where the needs of the organization is outpaced, and the growth of the organization outpaces the infrastructure that they've developed to support that. So that's what we call operational chaos. But then once an organization rounds out the infrastructure, begins to think about the group strategically, and begins to make progress on developing the strategies and path forward for the group, they move into strategic focus, they begin to take on value, and once they excel in that, they become high performing. And so all those payers I just talked about are force organizations to move to the right of this curve. All those market factors, all those payer factors, among other things, are what driving organizations to the value phase, to the high performing phase, out of the operational chaos phase. And as you think about organizations moving towards that value phase, they have to adapt their internal operations. That includes a lot of things. There's a lot of changes they need to make in terms of how they operate to succeed in that value phase. But obviously today's topic at hand is provider compensation. And you can think about how organizations within a value phase need to really think about compensation differently than organizations in growth mode or operational chaos. Because organizations in growth mode, usually if they're acquiring practices, they're just making offers to get the deal done. The things they need to tackle there is, centralization of physician deal making, standardization, things like that. Organizations in operational chaos usually need to focus on right sizing the compensation and creating alignment between compensation and productivity. Once an organization gets into strategic focus and they have the infrastructure, they can develop more standardization, centralized compensation philosophies and frameworks. They can begin to introduce non-productivity incentives, but it's really in the value phase where organizations will expand the amount of dollars allocated to non-productivity incentives, also evolve the type of quality metrics they're using. Maybe we're not only using process metrics, but outcome metrics at this point, and also begin to think about incentivizing team-based care, and also a lot of times even questioning the need for productivity incentives for certain services or certain specialties or service lines to begin with. And so that progress through these network growth phases really causes organizations to need to make changes, as I said, to the compensation methodologies. And we're also seeing that in the data out there and in the survey numbers out there as well. So if we look at things like Sullivan-Cotter or AMGA, which is the American Medical Group Association, and we basically look at those survey data to ask questions like, hey, how many groups are using quality-based incentives when they're building compensation plans? And now we're at the point where it's more than half. Primary care groups are 55%. Medical and specialty groups are 50%. And if we think about, what's the average amount of total compensation that goes to quality or value or otherwise non-productivity, that's growing as well, about just under 10% across primary care, medical, and surgical. And if we think about the types of non-productivity incentives, very common for organizations to use patient experience, process quality outcome measures. Those are the most common. Then, kind of that second tier, things like citizenship and patient access. Not very often, but it is seen out there in the survey data as kind of financial or cost reduction methodologies or incentives or things like that. So Neil, Terry, anything else to add to that to kind of set the stage on why organizations are kind of moving towards value-based compensation and why organizations are evaluating their compensation plans?
I think, Eric, just to reemphasize, as the network matures, it can undertake risk, right? Because it's worked on its management infrastructure, and it has the ability to support the types of things that you need to do to be able to incorporate these kinds of things into your day-to-day operations and be able to be successful in that. And in doing that, then you can start to take on more risk in the pay-per-performance world or the value-based world. And bringing your comp model along with that then incentivizes your providers, your physicians and APPs to be in line with that thought process of where the organization's going, and aligning, the goals and objectives and incentives within the comp model with the goals and objectives and incentives within the network and its risk contracting programs as well. And now you can better leverage the group and its physician and APPs to meet those challenges as you move forward and as the group matures. And frankly, sometimes the market forces you to do that before you're even ready, right? And you don't get the anticipated benefits of that. So allowing, for maturation of your operating system, the infrastructure associated to be able to support these changes is huge. And then bringing the providers along in that is then key to success.
Yep. Great. Thanks, Terry. So I think I'll turn it over to Neil to kind of talk about the second half of that, which is to say, okay, so it's clear that it makes sense to be evolving our compensation plans as our organization evolves, and we understand the factors that are causing our organization to evolve. But the next logical question is, okay, well, what do we need to think about as we're either reevaluating or redesigning or building new frameworks? And for that, I'll turn it over to Neil.
Yeah, thanks, Eric. So I mean, I think so when we talk about best practices with physician compensation, I think the first step is selecting the right framework, because we don't think that a single framework works in every circumstance. You have to choose a framework that suits the specialty, that suits where the organization is, thinking back to the growth phases curve that Eric talked about. Where are you in that maturation? We need to have a framework that reflects that, that's going to help us move along that curve to the next phase. A framework that either reflects our culture, or allows us to put incentives in place that will impact our culture. And again, as Terry talked about, as you get into it, and it probably applies a little bit more under number 2, but what are our resources and capabilities? So the next number 2 would be then, and we think that the framework that we'll talk about is overall, I think it's a simple concept. Obviously, you can take the most simple concept and make it as complicated as possible, and we don't advocate doing that. But in general, a simple concept, and then within that concept that we're going to talk about, which you see here, the base plus productivity plus non-productivity incentives, and then other compensation on top of that. In general, is simple, but it's also adaptive and flexible, which will allow you to adapt not only to specialties and unique situations and services, but also as we mature as a practice or as a network. And we highlighted there that productivity incentives is probably the one that we see maybe fall out with certain specialties, particularly hospital-based services, your hospital medicine, intensivists, anesthesia, some of those specialties where maybe we don't want to focus on volume, where the providers can't really control the volume, and so that might be an incentive that maybe falls out for consideration. So on the next slide, before we kind of get into the details of the framework that we think works best, talk a little bit about kind of the spectrum or the menu of compensation models that we've seen in the marketplace. Straight salary at the top is one we don't see a whole lot, and these days I think if we see it, it's typically not a standalone. There might be straight salary plus some non-productivity incentives, but in general, if you think about straight salary, it's going to be applicable to really unique organizations. I think we tend to think of the Mayo Clinic, Cleveland Clinic, those types of organizations. One where they're able to recruit and attract a certain type of provider. Typically has to be a provider that's internally driven, and so they have to fit with that culture. There has to be some control of patient scheduling. They're going to fill the schedule for you. You're going to see the schedule. And some of the other pitfalls, it's probably not going to encourage engagement in organizational initiatives. And then I think we see a lot of times with a straight salary, it tends to be a year-to-year thing. If you're not performing up to standard, then your contract's just not renewed for the next year. So that's again going to be applicable to a very unique situation and organization in order to work. Revenue minus expenses, we basically is your private practice model, if you will. We don't see this a lot. We have seen it in organizations. We've seen it with organizations that are trying to get away from it because it's become a challenge for them. Obviously, it tends to favor the bottom line. Like the straight salary, it's probably not going to incentivize somebody to be involved in organizational initiatives or non-revenue generating activities. It requires you to really hone in and be able to properly track and report and allocate expenses. Physicians are going to get focused on that. And so they're going to let you know when you're not doing it right. It's also going to cause them to micromanage the practice. If you're wanting to add additional resources to manage patient population, if you're wanting to add an advanced practitioner, they may say, hey, that's going to affect my bottom line, and that's not something I'm in favor of. So again, it's a very very unique situation for it to work, and it's not one that we see a lot of these days. Straight productivity, again, tends to be favorable to the bottom line because we're paying for the services that are provided. The downfall, the pitfall to it is that it becomes very myopic for the providers. They're focused only on what is theirs. Like the other two, they're not going to be focused on anything that's outside generating revenue or volume. It can be a barrier to recruiting and onboarding new colleagues or adding new providers, as I talked about, adding an advanced practitioner. Because again, they're going to worry about anything that's diluting their volume and hence their income and affecting their income in a negative way. So again, it's going to be a challenge. This type of model, it's not going to support more of a team-based approach, or organizational goals and objectives are going to probably fall to the wayside over being able to generate their personal income. The last model, which is the model that we'll talk about in more detail, is the salary plus incentives, which, as I mentioned before, is highly flexible. And just like I mentioned, it's simple overall in terms of concept, but like anything, people can overcomplicate it. And so that's something we have to guard against and make sure that we don't do. If we don't have the right mechanisms in place, if we're not asking the right questions, and we'll get into a little bit of the details in those areas, it can behave like some of the others. If we don't have if we have productivity incentives, but we're not adjusting base salary, it behaves like a straight salary. It can behave in certain situations. If there's extreme focus and emphasis on it, it can behave like a straight productivity model. So again, it's the devil's in the detail, and it has to be structured appropriately. So next slide. So here we won't spend a lot of time on this slide. This is just a picture of our overall framework that we're talking about. We tend to kind of refer to this as our layer cake. Kind of building from bottom to top, the base compensation and the size of the boxes there, kind of represents the proportion somewhat. Base compensation tends to be the larger percentage of total compensation, at least for most providers. And then, the productivity incentive, non-productivity, and then other compensation, which typically it does factor in, particularly as you're talking about fair market value and commercial reasonableness, particularly commercial reasonableness, the other compensation factors in, which tends to be, stipends for APP or APC supervision, so our advanced practitioner supervision, and then medical directorships and leadership. And so, it's really on top of, but the way it factors in is it has to be realistic that they're providing other services on top of expectations for, direct clinical care. So next slide. So starting, with the base compensation, some of the key questions and considerations that have to be asked. How is the base salary determined? Is it a departmental standard? Is it provider specific? Or are we allowing a bunch of one-offs? I think we favor having some standards and some parameters around that. There needs to be some standards, but also some flexibility that's built in to allow us to recruit people. Adjustment for FTE status. If we think about if we're gonna, for a specialty, if we have a standard of a certain level for a certain specialty, then adjustment for FTE status. If somebody's working less than a full schedule, then their compensation probably should be proportional to what we have for a full-time FTE. The base salary, typically we want to see that aligned with realistic productivity expectations. Again, back to what we talked about before, if it's not, and we don't have the mechanisms to adjust, then it can behave like a straight salary. And so that's not probably the incentive we want to set. And so we have to be cognizant of that and make sure that we have realistic productivity expectations and the systems in place to adjust. And then obviously we must balance the ability to recruit with financial sustainability. And there's also the factor of, when somebody comes in, into practice, are we setting the salary too high that they, after the guarantee period is over, are they going to be able to sustain it? Or are we going to have to reduce salary? And so you can sometimes maybe offset that with signing or retention bonuses, but just some things that you have to keep in mind when you're trying to balance, again, recruitment with sustainability and the financial needs and sustainability for the organization. As we talk about adjustments to base salary, when do we do that? How often do we do that? Monthly is typically way too much and too cumbersome and a lot of work for the administrative team. And so an annual or quarterly or even semi-annual adjustment probably makes sense. What's our methodology? We typically want to tie that to a rate that we'll talk about. Adjust the limit. What limitations do we want to have to protect the providers? If someone's down below their target for 30%, do we really want to cut their salary 30%? So maybe we have a limitation to how much we adjust back. And do we have the organizational wherewithal? We see a lot of organizations that, if you look on paper, they have these mechanisms in place, but do they really have the wherewithal to do it? And we feel like you need to have that wherewithal. If you're going to have it in the contract, if you're going to have it as standard, let's not set the precedent that we're doing it when we feel like it, and that can create problems with culture. So if you're going to go down, if you're going to have it in the contracts, then let's do it. Exclusion for certain specialties or extenuating circumstances. If it's a specialty where we have more than the demand, because we're trying to maybe cover the ED, because we have, trauma certification requirements, so we know the volume's not going to be there, we probably don't want to adjust the base salary. If somebody's been out, if they've taken sabbatical, if they are out for FMLA or something like that, they've had a baby or something like that, that might be a certain circumstance where we don't adjust the base salary. Terry, Eric, anything to comment on with base salary?
I don't think so, Neil. I think you covered it very well.
And I think especially that extenuating circumstances, not applying everything to everybody without critical thinking, and that critical thinking component I think is key.
So the next layer would be the productivity incentive. As I alluded to early on, selecting the right framework based on the specialty. Shift-based services where they can't influence volume is probably one. Where, again, hospital medicine, intensivist, those sorts of ED, those sorts of services. Perhaps having a productivity incentive is not what we want. You see a lot with hospital medicine that there's a sweet spot in terms of patients per day, somewhere around 17, maybe just shy of 20 patients per day per physician. And so beyond that level, we maybe have diminishing returns into areas that we care about, patient satisfaction, quality of care, efficiency, those sorts of things. And so having a productivity incentive maybe doesn't make sense. And again, the physicians can influence it. So, may not be something that we want to have in that particular situation. So again, the flexibility, the framework is we drop that out. We don't have that component. How often do we pay? We do see with productivity incentives, we see some organizations do monthly, which again is a lot. I think we tend to favor doing quarterly. Annually maybe is not often enough. We're asking the providers to wait to the end of the year, which really puts a lot of emphasis for them day to day and month to month on the base salary, which obviously is going to push that up. So we think that quarterly tends to make sense. If you have the resources and can make monthly work, that's an option. Reconciliation, if we're below targets, how do we handle that? We like to see a structure where we minimize paybacks, where we're not asking for actual dollars back, that we're either withholding, or those dollars are spent. Asking for providers for money back is never a good situation to be in. How do we determine the target or threshold? We've seen some people link and some organizations link to certain percentiles. We like to tie to a rate and have that rate become kind of a central cornerstone to the comp model as it relates to base and productivity. And so that makes the math work out. It helps it to be equitable within a specialty. If we're using the same rate, so regardless of where they start out in terms of their base compensation, if they both end up at the same level of work RVU production, two physicians, then they earn the same amount. One may have started at $100,000 less than the other, but if they end up with the same RVUs, they earn the same amount of money, which we think is a desired situation for the organization. So that kind of leads us into the rate, and the rate is critically important. And so if we go to the next slide, and if anybody's spent any time with the MGMA data dive, they're familiar with the scatter plot here that plots on the x-axis work RVU production, and then on the y-axis the total compensation. And so what we tend to look at, Eric, go to the next slide. Ideally, if we're selecting the right rate, total compensation is going to end up in that area that's kind of with the box around it there. So the green and some of the gray area there. If we have really well aligned compensation, so our productivity is favorably in line with our total compensation. And so we're along that 45-degree angle with some reasonable distribution. And we're not, in the red or the yellow quadrants that you see there. So the next slide, Eric, if you will, those, if we're outside that range, so we don't have the right rate, or we've put too much into base compensation, or another bucket, the non-productivity incentives maybe are not appropriately set as well. We could end up in the right quadrant, the upper, I'm sorry, the red quadrant, so the upper left quadrant. There, we're basically paying higher, significantly higher, as you'll see there in most cases. We're paying higher compensation than we're receiving in work RVU production. And again, in certain situations that might be acceptable, as we talked about, trauma and ED coverage and needing physicians for that level, you're going to have to document that for compliance reasons. But that could be an issue if we don't have the right rate. On the flip side, if we're not setting it high enough, then we're going to be, the flip side of that, we're going to be paying lower than the level of production, and then we have retention and attrition issues that maybe pop up. So selecting the right rate, I think one thing that we definitely always want to caution people is a lot of the surveys, MGMA, Sullivan Cotter, AMGA, they publish a comp per worker RVU ratio. And we like to say, please don't use that ratio to use as a comp rate, because this is not a survey asking organizations or practices what rate do you use in your productivity models by specialty. It's basically, this is a function of the math where they say, tell us your W-2 compensation, tell us what that particular physician's work RVU production was, and then we divide the two. And so what you end up with is a range of rates and not a range of bonus factors. And so if you have somebody that is on a high base salary, maybe somebody that's starting out in practice, that's still ramping up, that's a new recruit, divided by their high salary divided by their lower level of production, you end up with a high rate. And so you end up with a 75th or 90th percentile rate. That doesn't mean that's a 75th or 90th percentile physician. And so this is not a bonus rate that you want to use. Alternatively to that, if we go to the next slide, what we think is trying to look at, marrying up the level of compensation with the level of production, factoring in that, one, we have a benefit structure, and so we have costs associated with that we have to think about. And then we have those other buckets of dollars that are coming to the physician. We maybe have the other compensation. More specifically, we have the non-productivity incentives. So that all of those dollars are going to factor in to give us total compensation. And so if we think about total compensation divided by the work RVUs that are produced, that's going to give us, the actual rate per worker RVU that makes sense. So setting the rate, there probably needs to be a bit of a gap. And so if we're expecting a base salary that's at the 50th percentile, we might ask a little bit more in terms of work RVU production. So in this example, if we're at 50th percentile in terms of compensation, we might ask for 60th percentile in terms of production. As you can see in the example there at the top, which we've labeled the financially sustainable target zone, 59.93. And so that, when we factor that in, one, it's financially sustainable. Two, when you factor in the other sources of compensation, it's going to make sense. And so that would be a better approach to determining the rate if we're using benchmark data than trying to select and use the published comp per work RVU rates.
Yeah, and Neil, I think the thing I'll add too that might determine where an organization might pick a rate is there's other factors as well, including the financial condition of the organization. And if you think about things like payer mix and how strong the commercial contracts are and commercial rates are and things like that, those are factors where if you're a very financially healthy organization in a good payer mix environment with good commercial contracts, you might be able to kind of live on the higher end of this scale versus, if you're in an organization without some of those factors, you really got to think about, can you afford this? And that's a level of granularity that's tough to get to when just opening the book and looking at the rates, like Neil said.
Yeah. So I know we're getting close on time. So the as we get to the end of the presentation, the last few buckets, obviously the critically important these days is all the reasons that Eric covered as we talked about. having those non-productivity incentives in place is really important. A lot of organizations starting to realize that and move that direction, based on payer reimbursement, where their market's going, and so on. And so just like the question with productivity incentive, a key question is, how often do we pay? A lot of times the measure is going to determine that. It may be that, patient satisfaction, maybe we only get the report that we're looking at annually. And so that would determine how often we pay. So having enough data is going to determine that. So understanding what your data availabilities and abilities, do we have enough staff to measure it? Do we have the right systems? Those sorts of questions have to be considered. Selecting the measures, provider input is critical. You need to have the providers engaged and providing input into appropriate measures. Regularly updating within the framework. So if we're hitting the targets that we've selected for a particular measure, probably time to move on, either do something else or move the goalpost and move the target up a little bit. The number of measures, particularly starting out, if this is new, we want to keep it small. I think keeping it small just as a rule is probably the smartest thing to do, but particularly as you're just starting out, keep it small and keep it simple, get some experience, and then start to build from there. And then by specialty, I mean, there's a variety of metrics that are out there that are specialty specific, and so we should apply the ones that are critical and to that particular specialty. What is the target structure? Is it a single target, kind of all or nothing, or are there multiple variation or tiers within that structure? Again, probably depends on the measure, depends on where we are, in terms of our current performance, but all things that we have to consider and talk about. And then what is the dollar structure? Is it a fixed amount per provider? Is it a percentage of base salary or percentage of total comp? Is there a trigger for participation in the quality bonus? Do we have to hit our productivity target in order just to be eligible? It's something that we've seen some organizations do. I'm probably not a big fan of that, but it's something that some organizations would, have done and would consider. Terry, Eric, anything to add to that discussion?
So I think this is that evolving area that's just as large and perhaps larger than the productivity incentive. And we could spend the whole hour talking about this, but these are the salient points to consider, and it's not that simple.
And I think I'll reiterate something Terry mentioned earlier, where, some of the decisions an organization will make along these questions really depend on the infrastructure it has and its abilities to, measure the quality data. What type of quality reporting program does it have? And, how good is the organization at thinking about quality data? That's really going to influence a lot of, decisions that might get made in this area.
And as you talk about provider input, as you start to talk to them about measures, they're going to be cognizant, probably know what we can and can't measure. So if you haven't already figured that out, I'm sure they'll be able to tell you. So the last bucket here is, again, other compensation, which is typically on top. And again, the way that this really incorporates with the others is that we have to be cognizant of what the expectations of one are versus the other. So our expectations of clinical performance and duties and availability has to mesh with the other compensation. We can't ask somebody who's expected to work 2,300 hours a year in a clinical capacity, perhaps too much to ask them to have 1,000 hours of medical director duties as well. So we have to be cognizant of that. The other thing that we'll mention is the APP supervision. We've seen it done a number of ways, a lot of ways that we're not a fan of and we wouldn't support, from a compliance perspective. So Typically, we like to see it as a stipend. It can be a tiered stipend based on, perceived level of effort. Training new APPs on the front end is maybe more valuable and more time consuming for the providers than ongoing basis. It could be tiered based on the production level of the APPs. So all things to consider, but I think a critical point to the APP supervision is making sure that we're getting the value out of it, and that we have expectations, that it's not just a freely and expected bucket of dollars, that there's expectations for that stipend, that they're available to the APPs, and again, we're getting the value that we want out of that investment.
If I could clarify, when you mentioned based on the production of the APPs, that's a proxy for the level of effort required to mentor and review charts and those kinds of things, as opposed to receiving remuneration based on somebody else's performed services, right?
Right. Yeah. Good point, Terry. Good point. So I think that kind of wraps us up with the overall presentation. So this would be the point where we answer questions.
And I believe we'll be available via email. So if anybody has any questions throughout this presentation, given that it's pre-recorded, the best way to ask those questions is just to email Neil, Terry, or I. And we really enjoyed walking through this with you all. Thank you.
Thank you.